Yeah. I am a orthopedic surgeon at MD Anderson, and I focus on oncology as well as spine surgeons. So I did training in both, and so my areas of interest, kind of the overlap between the two. And I'm going to talk today about the use of surgery in elderly for the management of metastatic epidural spinal cord compression. So if a surgeon came into the room and said to you, you have metastatic cancer to your spine and you're going to be paralyzed unless I do surgery, how many of you would do surgery, would select surgery? And what if Dr. Smith came in and said the same thing and said, you're going to be paralyzed unless I do radiation? Would you select radiation? Yeah. And I think the understanding is that radiation may be less invasive and less risk. And one of the things that, if we look at the data, there is significant risk with the surgeries that we do, and there is a significant mortality risk with the surgery. So we'll kind of go through this stuff. This is a new project, so we just got started on this project, and I'm new to health services research, so I welcome your comments on design, and we're going to be going through this project in the months to come, so it would be helpful for your feedback. So in 2008, there was a study that came out trying to figure out how many people were living with metastatic disease to the skeleton. And in that population-based study, they estimated around 280,000 people were living in the US with metastatic disease to the skeleton. So that's a significant number of people living with these conditions. And when metastatic disease goes to the skeleton, the most common site of disease is the spine. And you can see this little, this MRI here. This is a MRI of the spine, the lumbar spine. The whiter, brighter areas are normal vertebral bodies, and the dark spots are the disease within the spine. And this has been estimated to be up to 10% or so of cancer patients, but when a study was done looking at the autopsies, it was up to 70% of patients who had cancer who had evidence of metastatic disease to their spine. There are common tumor types that go to bone. Breast, lung, prostate, thyroid, kidney are some of the most common. And when the disease does go to the spine, it can invade not only the vertebral body, but the spinal canal and cause what we call cord compression. And that is what everyone's concerned about. The tumor pushing on the neural elements that are running along the back of the spine and causing cord compression, which can cause paralysis. And that's estimated to occur in about 20,000 cases of metastatic spinal cord compression occurring in the US per year. So what does that look like? What does metastatic spinal cord compression look like? And so these are MRIs, these are axial cuts of the spine, demonstrating different degrees of disease within the spine. So this is the front of the body, this is the back. Here's the vertebral body here, and this is the spinal canal, and this is the spinal cord sitting right here. In this MRI, you see some disease sitting in the vertebral body, but is not affecting, eroding through into the spinal canal, not affecting the spinal cord. When you get down here, and it's hard because of the lights to see, but this is the most severe case where this is all disease wrapped around the cord. You no longer see the spinal fluid that's bathing the spinal cord sitting in the thecal sac. You've completely lost any of that fluid because the disease is compressing the spinal elements so severely. So that is severe spinal cord compression. And this is when we're concerned at these later stages that someone's going to become paralyzed. And people will present with really bad back pain. They can present with motor weakness or paralysis or some degree of neurologic dysfunction. So they can report bowel or bladder dysfunction, and it's usually difficulty urinating in the early stages. They can't empty their bladder because they lose control of their sphincter. Our treatment goals are pain control. We want, as much as we can, durable, local control of the tumor. We want to maintain and improve their neurologic function, and we want to maintain or obtain spinal stability. When we're talking about the treatment of spinal cord compression, we want to, of course, make a diagnosis, and we do that by imaging and by getting a biopsy. Someone may have cancer and have not yet received the diagnosis of metastatic disease. So when we see someone with cancer, if this is the first time that they're presenting with a lesion in their bone, we want to get a biopsy of that to make the diagnosis of metastatic disease, because you could have a primary tumor a primary bone tumor in the setting of a patient with lung cancer, for example. So once you make the diagnosis, then what? What are your options? And I just listed them here and put question marks behind them because we still have questions about how we treat these patients. So these are the things that historically have been used to treat metastatic spinal cord compression: steroids, radiation therapy, and surgery. So just going through some of the history, steroids has been used, and there's papers, and this is one of them that demonstrated the benefit in using steroids for treating these patients. The idea being that there's compression of the neural elements, there's inflammation in that area where the neural elements are compressed, and steroids, a potent anti-inflammatory medication, can decrease the inflammation in that space and give some more room for the neural elements. It worked and does work rather well, but there is a significant complication rate, and that goes up with the prolonged duration of use, and also with the dose. So when you give high doses of radiation, high doses of steroids, the risk of having a serious complication increases. And in this study, back in the early 90s, showed that in patients that were getting 96 milligrams of IV steroids, there were 8 serious side effects in this small group of patients, and 4 were serious, and there was 1 death. And we're talking about infections and GI perforations leading to bleeds. And so when we do give steroids, we try and protect their bowel with medications and try to give them smaller doses, and we'll go through that a little later. Radiation has been a mainstay of the treatment for spinal cord compression. Here's a study that was done in the early 90s looking at 209 patients that had metastatic spinal cord compression. It was prospective. They were using radiation and steroids, and they showed that they, in a large percentage of the patients, had relief of their pain. They preserved ambulation. So if the patient came in ambulating, they did a good job with radiation alone, radiation and steroids, preserving the ambulation. They didn't do as good, but were able to improve patients who came in either with significant neurologic dysfunction or paralysis. And they were able to recover some sphincter control, so patients who came in with bladder dysfunction, they were able to get some improvement from that. But not perfect, and it doesn't work on everyone, and the reason being that not all of these lesions are radiosensitive at the dose that we can give, keeping the spinal cord and the neural elements in mind. The spinal elements, the nerves, spinal cord, it is sensitive to radiation, so we have to be cognizant of the tumor location and the spinal cord and the dose that the spinal cord can tolerate. So here's just a general list of some of the different metastatic histologies that we see and whether or not they're sensitive or not. And you see myeloma, lymphoma are really sensitive, so this may be a very good treatment for them. And then other things are not as sensitive, and radiation oncology is changing now with stereotactic radiosurgery and things like that, so some of these things are changing. But in general, there are tumors that are not as radiosensitive, and there are tumors that are more radiosensitive, so we keep that in mind. And then surgery, and I use this slide to just state that in majority of patients can be treated non-operatively for this condition. And we look through the literature, and we look through the initial results of the study that we're doing, and we see that radiation is used by far the majority of the time. And in many cases, radiation and steroids can effectively treat this condition. But what are the surgical indications then? So I listed them out here. And I would say if we don't have a diagnosis, if we don't have tissue yet to make the diagnosis, that's one reason we would take a person to surgery to get a diagnosis in an acute situation. So if someone comes in with loss of bowel, bladder, or lower extremity function, and we don't have yet a diagnosis, we see a lesion on MRI, we need to get a diagnosis but also treat their condition, because we can't wait. So often we can't wait to get a needle biopsy and then wait weeks to get a diagnosis before actually doing something for this patient. So tissue for diagnosis, radio-resistant tumors, if they have spinal instability or bony cord compression. So in that first MRI, it showed the lesion in the vertebral body. When a lesion, a tumor erodes through that vertebral body, it causes it can cause weakening of the vertebral body, so much so that the spine is no longer stable. When a patient stands up, the forces going through their back cause intractable pain because the bone is cracking under the weight of that patient's body. So that's one reason radiation is not going to help that condition when someone has spinal instability, mechanical instability. So that would be a reason to do surgery. We talk about deterioration after radiotherapy, so if someone is progressing through radiotherapy. If they had tumor recurrence, previously treated, and now they have tumor that's coming back, that might be a reason to do surgery. They have persistent symptomatic disease despite getting medical treatments, and if they have intractable pain. So there are different surgical approaches, and just the history behind it. This is a study looking at two different ways to approach it, a laminectomy and a vertebral body resection. A laminectomy is the procedure that we do to unroof the posterior elements. So this is an MRI showing the spinal cord. There's disease in the vertebral body here. This is the front and this is the back. The posterior spinal elements, if you think of it as the posterior spinal elements being the roof and the vertebral body being the house. And so when you do a laminectomy, you lift the roof off of the house to give space for these wires that are traveling through the spinal canal. And so that is a laminectomy. A vertebral body resection is when you actually go into the front of the spine, and earlier techniques were to actually approach it from the front or side, and more modern techniques are to actually reach from the back into the front to get access to where the actual tumor is. And you remove it, and then you could reconstruct it with what's seen here. So this is a reconstruction after the removal of a vertebral body, and this is the AP view. So Siegel compared the two, the laminectomy pre-op, laminectomy post-op. So there was some improvement in ambulatory status, sphincter control. There was 20% of the patients who had neurologic worsening, and there was 8% of the patients died. When he compared the vertebrectomy, pre and post, had much better results. So 28% came in ambulatory, 80% walked out. 93% regained sphincter control. When they started, there was only 49% who had sphincter, or 49% had sphincter dysfunction. And there was a 7% mortality rate. So comparing the two, laminectomy versus vertebrectomy, the patients who had vertebrectomy did much better. And here's just a cartoon showing what we do in surgery. We do a laminectomy, remove the posterior elements, and then we reach around the spinal cord into the vertebral body in the front to remove the tumor that is pressing on the spinal cord from the front. And then we reconstruct it with some, usually bone cement or a cage. And then we put in rods and screws to stabilize things.
That's a posterior approach to vertebrectomy?
Exactly, yes.
How often do you do that versus an anterior approach nowadays?
So it depends on the location. In the, say, mid to lower thoracic spine, this is what we're doing. And the reason we can do this is because the nerves that come out of the thoracic spinal cord are sensory nerves. There's no motor function to those nerves, so we actually cut them and use that corridor to access the front of the spine. When you have tumors in the lumbar spine, no longer do you have the cord issue, but you have those nerves which provide motor function, and we generally don't like to cut them because we're going to lose some function in the lower extremity. So my approach to this problem is almost always through this type of posterior approach, reaching around to the front. And sometimes, in order to do this cartoon doesn't show it well, but we have to take actually more of the bone. This is a transverse process, and this is the rib. So oftentimes we'll take actually part of the rib out to get really far out so we can get all the way across from either side to get the tumor out. So these are newer techniques. I mean, they've been going, we've been doing this for a decade or so. But we're getting much better at doing this, so that's how we do it. The reason why laminectomy did poorly, and when you compared laminectomy to radiation alone, laminectomy and radiation versus radiation alone, the laminectomy and radiation did worse than radiation alone because if you look back here, there's tumor destabilizing the anterior part of the spine. The posterior elements were oftentimes the only thing holding that spine together. So there are ligaments and bone back here that are holding the spine up. When you do a laminectomy, if you just remove this area of bone here and take off all those ligaments and then treat with radiation, everything would fall apart. So people were collapsing because they had no more stability. We just wiped out all the stability that they had left. And so that's why laminectomy and radiation did worse than radiation alone, because the laminectomy did not address the anterior tumor and it introduced more instability. And the concept of stability is important for that reason. And so this is just a model showing this idea of 6 columns within the spine and looking at how many columns have been destroyed by tumor, and that helping us decide whether or not we should consider radiation, surgery, or an anterior posterior surgery for removal of tumor and reconstruction. Well, we talked about the mortality from surgery, and in those papers it was around 7–8%, but some of the other papers goes up to 30%. So this is not a simple procedure. And so when undertaking something with such risk, it would be good to know really what are the outcomes of surgery versus non-surgical treatment, and are we really doing people a service by operating on them? And so we've been looking for that answer, and people have come up with a number of different strategies to try and figure out who we should be operating on. And these are systems, which Takahashi was one author who came up with a system to try and figure out whether or not a person is actually in a situation that could they tolerate the surgery. So we look at their performance status, whether or not they had complete or incomplete palsy, what's the primary site, and come up with a score to figure out whether or not, what is their predicted prognosis and whether or not we should actually consider surgery. This is another a strategy here, or actually this is the Takahashi score when it's broken down and you get the number, whether or not you should do excisional surgery versus palliative or non-surgical treatments. This is another system to try and think about these patients. This is the Bilski classification, looking at the neurology of the patient, whether or not they have significant neurologic symptoms. What is the oncology? Very important. We want to know, is this a very radio-resistant tumor or is it very sensitive? It will help us guide treatment. Is there mechanical instability? If there's mechanical instability, then radiation alone is likely not going to help, and it could worsen the situation. And then what is their systemic, what is their overall health? Are these very sick patients and putting them through surgery going to actually kill them? This is important information, and we want to counsel our patients appropriately. So this is another algorithm. Who should we be operating on? And this just kind of drives us through this thought process of how to determine whether or not to give radiation versus surgery or what have you. In 2005, the Patchell study was published, and this was a big deal in our the spine surgery world, because this was a randomized controlled trial looking at this issue, whether or not direct decompressive surgical resection and treatment of spinal cord compression caused by metastatic cancer actually helped versus the radiation strategy. So It was a randomized, prospective, multi-institutional study. MD Anderson was part of that study. It was non-blinded. And there were 2 groups which were randomized. One group would be randomized into the radiation alone group. They received radiation and high-dose steroids. We were still using high-dose steroids at that time, and people were still dealing with the complication rates. Yeah, so this study it was really important in the Patchell study, and we hear it to this day from 2005 until now. It's cited a lot in at our meetings and in the literature. And again, comparing high-dose steroids plus radiation, and the radiation that was delivered was 30 gray, 3 gray per fraction, versus surgery, radiation, and high-dose steroids. And the surgery was not just simple laminectomy, but circumferential decompression and stabilization. And it was powered for 200 patients. The primary endpoint was the ability to walk after treatment. What they don't tell you, well, I didn't put here, is that the definition of walking was taking, I believe, 4 steps. And you could use assistance. So you could use a walker, you could hold on to something. So does that really mean that you can walk? You know, there's a question with that alone. But median follow-up was 102 days in the surgical group versus 93 days in the radiation group. It was actually stopped at the interim analysis. After 100 patients were enrolled in the study and analyzed, they stopped the study because there was such a big difference between the patients who were treated with surgery and radiation versus the radiation group alone. So the patients who had surgery, radiation, and steroids, they were walking after treatment in much higher numbers compared to the group with radiation alone. So they said there's a ethical issue with continuing this study because so many patients are doing so much better with surgery. So it was stopped. This is just a breakdown of how they went through their randomization, and they got equal groups, more or less 50 in the surgery group and 51 in the radiation group. This is their table they included in the chart, looking at the 2 groups, 51 in radiation, 50 in surgery. And it's just some of the things that I want to point out because it's just critical of the study, is that here are the tumor types that were included. They excluded very radiosensitive tumor types. So they excluded myeloma and lymphoma. But you'll see on here that they included some of these radio-insensitive types, like melanoma. They put in here other with sarcoma. So, you question whether or not we're really doing a good comparison here, and was it already biased towards the surgery group. The other big criticism of this paper was this right here. I'll point this out, unstable spines. So we talked about the stability being important, and I'm not sure how they got this through the IRB, because if you ask a group, 100 spine surgeons, whether or not they would recommend radiation for a patient with an unstable spine, almost everyone would say no. It's not indicated for an unstable spine, and yet these were randomized into the radiation group alone. And then during the analysis, there was a lot of crossover from the group that got radiation alone into the surgical group. And a lot of these patients came from this group here. So I think those are some of the criticisms that are pointed out and caused some people to question the results, the validity of the study. But these are the graphs that they show. This is the length of time. All study patients remain ambulatory after treatment. So these are all the patients who came in, whether or not they came in ambulating or not. And surgery, they stayed ambulatory much longer than the radiation group alone. This is the length of time patients who were ambulatory at study entry remain ambulatory. So taking away the people who came in with paralysis, the patients who had surgery, they maintained their ambulation at higher rates and for longer periods of time. So here's 150 days, 53 days versus 53 days. And then in the non-ambulatory group, they didn't have graphs for that in their study, but they had 32 patients who entered the study non-ambulatory. And there were 16 in each group. In the surgery and XRT group, 10 out of the 16 regained ambulation. In the radiation alone group, only 3 out of the 16 regained ambulation, and this was significant. And then I said that these are some of their other endpoints. They looked at maintenance of continence, Frankel score, Asia score, survival time. And they did note that 10 patients in the radiation group crossed over to receive surgery. They also noted in these secondary endpoints that surgery was, had a benefit. And they concluded by making a number of statements, and if you take some of them out of context, then you might come up with a different conclusion for treatment of these patients. So they first said, well, the results cannot be used to justify surgery in all patients with metastatic spinal cord compression, that you need to use reasonable clinical judgment, that surgery is effective treatment for metastatic spinal cord compression, but should surgery be the initial treatment? And then they summed it up by saying the best treatment for spinal cord compression caused by metastatic disease is surgery as the initial treatment, followed by radiotherapy. Well, when you gave this to spine surgeons who make money off of doing spine surgery, they ran with that and said, surgery is great, for these patients. We're going to improve their function. Everyone's going to win. Well, there was some flack in the society meetings, and they came back in 2008, wrote a review, and this was their summary statement, more or less. First-line therapy is corticosteroids, and radiotherapy is the mainstay of treatment for most patients. However, a recent randomized trial, their trial, showed that for select patients, the combination of radiation, of radical surgery and radiation is superior to radiation alone. And then this was the indications for surgery, and I had listed those before. Their criteria for surgery, and they're trying to now say, there were select criteria for the study, so these select criteria should be applied for the population of patients to try and figure out whether or not surgery would be beneficial. So patient with a radio-insensitive primary tumor, true displacement of the spinal cord seen on MRI, a single area of cord compression. A lot of these patients come in with multiple levels of disease, so this narrows that group down significantly. And they can't have been paralyzed for more than 48 hours. Well, the Cochrane collaboration put this out subsequently. Interventions for the treatment of metastatic epidural spinal cord compression. This is a review. Their objective was to determine the effectiveness and adverse effects of radiotherapy, surgery, and corticosteroids in the treatment of this condition. And their selection criteria was looking at randomized controlled trials of radiotherapy, surgery, and corticosteroids. They looked at the radiation and the steroids. Just to summarize more along the steroids, because that was the controversial piece, was that high-dose steroids cause more complications and did not have a benefit over intermediate dose steroids. So my strategy is using a bolus of around 10 IV and then doing 6 Q6 versus the 94 milligrams of steroids that people are getting in high dose. They looked at the Patchell study, and this is just to sum up their results here. And they pointed out, ambulation, able to walk 2 steps with each foot unassisted, 4 steps total. So they pointed that out. And then they noted 18 patients with unstable spines were randomized to radiotherapy alone. And then I pointed out that radiosensitive histologies were excluded, but radio-insensitive histologies weren't included. These are just the risk ratios that they shared comparing the groups. And they concluded that patients with stable spines, so if you have a mechanically stable spine and you walk in into the doctor's office, although you have some compression, but you walk in, you can be treated with radiotherapy and expect to have a pretty good result. And then there's evidence of benefit of surgery in ambulant patients with poor risk factors for radiotherapy, and then non-ambulant patients with single area of compression, paraplegia for less than 48 hours, non-radiosensitive tumors, and a predicted survival of more than 3 months. So people with metastatic spinal cord compression, they're not homogeneous. Surgery is effective in a select group of patients, and the patient selection is critical. So they went back and looked at their data and said, well, does age matter? And these are the graphs that they show here, and to sum it up, yes, age did matter. The younger patients, when treated with surgery, did benefit from the intervention, from the surgical intervention. So they ambulated longer And the older patients, greater than 65, did not achieve or experience the same benefit of surgery. So it was very similar outcomes between the surgical group and the radiation alone group. So there's the progression. Surgery, initially, Patchell study comes out, surgery is beneficial for the treatment of metastatic spinal cord compression. Everyone said, use it on everyone, and he said, wait a minute, there's a select group here, radioinsensitive tumors, single site of compression, no paraplegia for 48 hours, and then even still, wait a minute, the benefit of surgery is limited to the younger population. Cancer just published this group looking at the effect of that randomized controlled trial on surgical treatment of metastatic spinal cord compression, looking at 2000 to 2010, the national inpatient sample. This graph shows the surgical admissions over the total metastatic admissions. So just to show that with time, the surgery is being utilized more per metastatic admission. So we're operating on more of these patients. And here's 2005. So it was increasing a little bit, and then you see more significant increases. And it breaks it down into the different types of hospitals. So a teaching hospital seen here. The west is this one, and then smaller hospitals down below, and this is the average of all. And then they looked at the number of citations in the literature for the Patchell study. And here you see after 2005, so from 2006, we continuously, are increasingly citing the Patchell study, and oftentimes it's people saying, I'm operating on these patients because the Patchell study told me to, said that there was a benefit, but they didn't read the later data. This is some more of their results here, and they looked at not only the use of surgery, the number of citations in the literature, but what was happening to these patients. What were the outcomes before the Patchell study came out in 2000 to 2004 versus 2006 and 2010, and they had over 7,000 patients. And a couple things stood out. The number of complications that the patients had before the Patchell study came out that were taken to surgery were much less than the number of complications or percentage of complications in the patients that were operated on or taken to surgery after the Patchell study. So we started operating on sicker people, thinking that we could help them. And here's the total number of complications. So this is before 2005 Patchell study, this is post Patchell study. And the number of complications increased. And cost increased. So this is the median cost before 2005 was 60,000 or so, and then after 107,000. And the expensive hospital stays between those two groups increased. So I think we're operating on sicker people, and we are unfortunately dealing with the complications and the costs associated with it. So the question is, are we overutilizing surgery, particularly in this greater than 65-year-old population, with the background that we just went over and the Patchell study, those authors themselves saying that they did not observe that benefit in this population. So the questions I had was, what is the utilization of surgery in this population? And I should add to that, what are the outcomes comparing the surgical group versus the patients treated with radiation alone? Was surgery the first line of treatment, or was it used after failure of XRT? 'Cause that helps us determine, in some cases, the efficacy of the radiation. And then we also wanted to know what influences the use of surgery. Does hospital volume or hospital type influence the use of surgery? I would hope that those of us who are in teaching facilities, hospitals that should know better, should be using it less. But if you looked at that slide, the teaching hospitals were using surgery more than the small community-based hospitals. And I wonder, is it because we have the technical know-how to do the surgeries, and because we have egos and believe we can do it, we're doing it, whereas some of the surgeons in smaller hospitals don't have the resources to do the surgeries and say, yeah, radiation will be the best thing for you. So this is how we went through the cohort selection, and we want to look at both the SEER Medicare and the Texas Cancer Registry data. Right now, we just some preliminary data on the SEER, and we will work on that later. We wanted to include all the patients with a cancer diagnosis between 2002 and 2009, and these are the tumor types that commonly go to bone, so we want to look at those. We did not have the data available for myeloma or thyroid. We are including only patients who are 65 years of age or older, alive at the cancer diagnosis, and then they need to have a diagnosis of secondary malignancy of the spine. There is no true code for spinal cord compression, so we have to kind of use CERCIT codes to identify this population. They need a secondary malignancy of spine diagnosis, and then we wanted all the cases of metastatic spinal cord compression. And this cohort here treated those treated with either a surgical decompression or radiation. And we used a window of 30 days before and a year after, trying to capture these patients who are truly treated for this problem. And some patients won't actually have a cord compression code until after the surgery has been performed and they actually get a diagnosis, because sometimes we're actually doing biopsies at that time. And then they continuously need to be enrolled in both Part A and B with no HMO between cancer diagnosis and 12 months after.
So what is 336.9?
Yeah, so 336.9 is the code we use for abnormality in the spinal cord. So there's no, in ICD-9, there's no code for spinal cord compression, unfortunately. So we use that code, and that's the way we try to denote that there is something interfering with the cord.
So you can be reasonably confident that the surgery patients had something really bad
Yes.
going on with them, but it's really hard to pick out the appropriate radiation control.
Yeah.
Which might not be a huge problem with what you're interested in looking at.
Yeah. So we went, and I'm glad you brought that up, because we need some maybe help with this, and we've gone through trying different ways of trying to figure out how do we really get that control and narrow that down. So we excluded as primary tumors of the spinal cord and spine, and less than 65 and no treatment delivered. So patients who had these diagnoses but went on to hospice. So identifying first patients with cancer, we went to the cancer registry and based on the tumor site. And then we identified all cases of metastatic spinal cord compression by first looking at the ICD-9 codes to determine if they had a secondary malignancy to spine. And these are the two codes that generally give us this information. And ICD-9 is not great because these are not so very specific and granular, but 170.2 is a malignant neoplasm of the vertebral column. So if they have a cancer diagnosis, lung, thyroid, etc., and then they have this code here, the chances that they have a primary malignancy of the spine is pretty low. So we're assuming that this malignant neoplasm of the vertebral column is from the primary cancer. And then here's the 198.3, secondary malignant neoplasm of the brain or spinal cord. So again, if they have one of these codes, we're assuming that that code is a secondary malignancy code because the incidence of primary bone tumors in the US is around 2,500 cases of primary bone tumors. And then majority of them are in the extremities. So the numbers of primary spine tumors are probably 100 or so per year.
I'm not trying to be critical.
Be critical. We appreciate it.
My sense was that you only were supposed to use that code if you have a primary tumor there. If you have a metastatic lesion to, say, your vertebral body, you would just code 198.5, which is the ICD-9 code for bone metastasis, secondary vulnerable bone.
Yeah.
I mean, do you know, like I thought, have you asked like a coder, because I thought the coding rule would be that that would be a primary vertebral column neoplasm.
Yeah, so good point. And unfortunately, coding is very variable. And having been in both academics and private, the private world, and seeing who is actually doing the coding and what they're actually coding, this is being coded, I think, a good number of the time.
Because, for example, for another tumor relief, if you operate on like the metastatic lung disease, I see it all the time when the bill is actually sent back for me to review that it's been coded as a primary lung tumor, when 9 times out of 10 when we're doing that, it's not.
Yeah.
And I think, I think even with the private, it may even be greater, smaller institutions who don't have departments dedicated to the billing, where the physician or the surgeon's doing the billing themselves. So that I would agree with.
When we put in our radiation prescriptions, we have to put in the ICD-9 diagnosis code, and so like the few that I have memorized are like 198.5, which is bone med, and 198.3, which is brain med, and 174, which is breast, and 233, which is DCIS. So I always would build these as like 198.5, but so I think you would miss some of those with this strategy, but I think mainly what you're interested in is like how bad are the surgery patients doing, so I don't think it's like...
So you would say to add 198.5, you think?
Yeah, but the problem
is
you're going to get people getting their hips treated and their humerus treated.
Right. So we were trying to,
I don't know what the right thing to do is.
Yeah.
It's just a problem. Maybe ICD-10 will be better.
Yeah, so ICD-10, I think there's problems with it, but it does break it down to size, and laterality and things like that, but there's still some big problems with it. So, so they had one of these codes, so they have a cancer code, they have either one of these codes, and then they have this code. And this is unspecified disease of the spinal cord. And this is the code that we kind of use for spinal cord compression. And with these codes adding up, we thought that this means that they have spinal cord compression and is the cohort we're looking for.
So you might, if you're going to require 336.9, you might want to do a sensitivity analysis and see if you put in 198.5 as one of the three ORs, see how many more patients
we get.
Because then that 336.9 at least makes it more specific.
Yeah, okay. Thank you. So these are the CPT codes that we included for surgery and cervical or thoracic decompression and instrumentation. Any of the codes that refer to this is what we were looking for. And then here are the CPT codes for the radiation therapy. And
so Justin, in about, I forget what year, 2007, 8, or 9, there were new CPT codes introduced for radiosurgery. I think they're like 77375 or something like that. I don't think you have them in that list. So
we'll have to check, and I don't see it here, but I did look at that and created a spreadsheet, and I needed some help because your coding is very difficult. So yeah, so there were codes for treatment, for planning, and then actual delivery of the treatment. So I had to I was looking through that, and I guess there are certain patients who could get planned but not actually get treated. Then there were codes that for the stereotactic spinal surgery. And then they changed the codes, so updated the code. And I think it, and we'll have to look, but I think we had those codes there, but we'll double check.
I think you might be missing the one for stereotactic treatment delivery, which is the body. But whoever you're working with in radon can help you, or I'm happy to help you.
Okay, yeah. So initially we had all the stereotactic codes, but then they're actually specific to a cranial lesion versus a spinal lesion. So I thought we captured the spinal lesion codes, but we will double check, and I might be calling on you to help with that. So, and then the treatments, whether or not they had surgery, and whether or not the surgery was either primary or secondary intervention, and then the same thing with radiation. And then some related factors. So the hospital size, and looking at hospital size, I was not familiar with how to do this stuff, and Ying has helped out tremendously. But I thought, well, we just capture the number of cases of spinal cord compression, and we may not have that data available. It might be one here, one there. And so some of the other options that were suggested were just looking at the number of beds at each hospital and using that as, to determine what kind of volume that hospital is seeing. And then some characteristics about the institution, whether it's a teaching institution or community. I don't know if you guys have any suggestions on doing that.
So the SEER Medicare data we have right now, we actually have the unencrypted hospital ID. It's because I told my wife like 6 years ago that might be a good idea, and not realizing that it would take a year out of her life. And then we never did anything with that, so I've always this large burden of guilt. But you can use that, for example, to like pick out the NCCN cancer centers, for example. So you can just look up the provider ID on the CMS website for all the NCCN cancer centers, and then you can create a flag variable to say, operated on an NCCN center, for example, or anything else that you wanted to do relative to that. So if there's certain things, certain hospitals you want to look at or look up, you can create flag variables to indicate your patient was treated there.
Okay, great. And then some of the other variables, so age, sex, comorbidities, socioeconomic status, and here are the outcomes that we wanted to look at. So the length of stay in the hospital, complications, and then this was a list that I just pulled for the different complications and the codes that we would be looking for. Reoperation rates, mortality, median survival cost, and then discharge status. And then here's our preliminary results just based on the SEER Medicare data set, and we found, looking at that, using that cohort selection criteria, we got 1,548 cases. And here's just a chart of the time between the cancer diagnosis and the diagnosis of spinal cord compression. And so the median was around 3 months from the time a patient was diagnosed to getting spinal cord compression. And then here's some of the data just looking at the treatments delivered. And we talked about earlier that radiation is the mainstay of treatment, and that's what we see. The majority of the patients were treated with radiation alone. But in this cohort, we're still seeing patients, a good number of patients that are treated with either surgery first or surgery alone. And then there's a group here that had radiation first and then went on to have surgery. Here's how the age breakdown looked. So pretty even numbers, more or less. I don't think anything really stood out. And then males were a little bit more in number than females. And here are the racial groups here. So non-Hispanic whites were the majority of patients treated. And here are the cancer sites, and lung was the largest group of patients, and then prostate and breast. And here's the use of surgery by year. So here's the years here and the percentage of patients that were actually treated with surgery as the either primary treatment or only surgery. And so over the years from 2002 to 2010, we see this increased use of surgery, which is what was also reported in the literature. And here's a graph showing that data there. So we just see this increased use. We don't have all the data for 2010, and Ying can better explain that. But and so we're not. This may not be truly such a increase. And then I wanted to see the the use of surgery relative to the use of radiation. So I thought that if we looked at the ratio over the years, if surgery was increasing or at the same rate as the use of radiation alone, then we would have a flat line over the years. And what we're seeing is this increased use of surgery. And here's 2005 here. And so after 2005, the Patchell study, this is what we're seeing, this increased use of surgery. I think that second study that came out looking at age was somewhere in 2008. I don't believe that this has anything to do with that, but I'm not sure. But we're seeing increased use of surgery in this elderly group, which to me is somewhat concerning because we have data saying that it doesn't really help them as much as it does in the younger patients. They are increasingly sick, they're increasingly complicated, and the surgeries are increasingly causing more issues with their quality of life. And so I think it's interesting that we're getting this preliminary data, and our next steps are looking, of course, at the outcomes between these two groups, as we already mentioned, and then looking at the influence of the hospital volume on the use of surgery and the outcomes. And then we also want to look at the TCR Medicare data set. And I'd like to thank my colleagues on this, Dr. Suarez Almazor, who's my research mentor for this project. Ying has been teaching me how to speak the language of population-based research and guiding me through this process, as well as Dr. Elting. Ashley helped me before this project, just sitting in on some of her meetings. She's in radiation oncology and she does some population-based research, so I was able to sit in on some of her meetings and get the ball rolling, just learning how to do this. This is something new to me, but I think there's a lot of value in it, and we can get a lot of good information from it. So I'm happy to be a part of the CERCIT program, and thanks to Ben and others, I'm here. And Stephen was also the analyst that helped Ashley in her work, and I'd like to thank you guys for listening, and any comments or questions, happy to take them.
So these are only patients over 65, right?
Yeah.
So
these
all
are
of these patients should not be getting surgery according to the Patchell.
Yeah, so, right, so exactly. So from that age study, they did not observe the same benefits. So it looks that the outcomes were pretty equal in the over 65 age group between surgery and radiation in terms of ambulation. There are other factors to consider, but looking at that data. I'm sorry?
The cost was more.
The cost is more, the complications are more. And in the lung cancer group, the median survival of a patient with metastatic lung cancer to the spine is about 3 months. So are we really helping those patients if they have 3, 4, 5 months left and we operate on them and they run into complications, they're in bed, they don't really regain much valuable function? What good are we doing? And we're taxing the system. So. I put everybody to sleep, so now we.
Yes, you haven't looked at like 30-day mortality yet.
Not yet. Yeah. So that.
That'd be really
Yeah.
interesting to see.
Yeah. So.
Extended even further, so like 90 days.
So we were going to look at both. Yeah.
As far as lung cancer, it might be interesting to see.
Yeah.
I mean, one could reasonably argue that doing an operation if you have 30 days to 90 days is not.
Exactly, and that's why some of those things that I showed from Takahashi, the papers from Takahashi and Tomita, we're looking at that, and it would be good to see in a population-based study, how that bears out, because they spend a lot of time coming out, and we talk about these systems to try and prognosticate patients and give them a life expectancy and base our surgical treatments or radiation treatments on that, but it's hard to do with some patients. All right, thank you.